scientific advisory board, and somebody I always put for some reason at the very end of the day between you guys and lunch, so apologies to him on that, but he's going to give a very important talk on advanced sarcoidosis.
Yes, and I only have 5 minutes to finish it up, so that's good going. Thank you. So I have some pharmaceutical support that I want to put up here, and I want to thank actually most of my patients have over the years realized that I've been very interested in alternative therapies for sarcoidosis, many of which you heard of today, that we have developed over the years. One of the things that I wanted to talk about is this concept of advanced disease. And the reason why we're getting into this is because although I've been dealing with this disease for over 40 years and developed a lot of drugs, and I thought we were doing well because we had more drugs. But embarrassingly, the mortality and the average age of sarcoidosis has been rising over the last 40 years. And that one of the things about sarcoidosis that many in this audience have been frustrated with is how you've been told it usually does very well. And so there is a subpopulation of patients with sarcoidosis who do not do well. And I think we're trying to shift from this concept that everybody's going to do well to pointing out that some people don't do so well. We don't want to make the total shift that everybody with sarcoidosis is going to do poorly, because in fact, some of them don't have any problems. They do well. At least half the patients with sarcoidosis are going to never need therapy, do well. And it's the sarcoidosis is a disease of halves. Half the people with sarcoidosis don't need therapy from the beginning, and of those people who are on therapy, half of them will be able to get off the therapy by 2 to 5 years. But I'm going to focus now about that 25% who are on long-term therapy, and about half of those can be maintained on a little bit of steroids. The Johns Hopkins group for many years said you just need to give somebody that ideal dose of prednisone for the rest of their lives and they'll do well. Not everybody can find that ideal dose, and somewhere between 10 to 15% of patients continue to go up and down with their therapy. So we're going to talk about advanced disease. Another shift in the ideas about sarcoidosis is that we're trying to take it away from the physician exactly how to treat patients with sarcoid. This is Athol Wells, and I like to call this Wells Law. Athol Wells is a gentleman in London who pointed out there are only 2 reasons to treat patients with sarcoid: danger, fear of death, fear of organ, or quality of life. And it's important to realize that if quality of life is not the physician's decision of what your quality of life is, it's yours. So if I have over 2,000 patients with sarcoid, and I try to make it important when I talk to my patients about their sarcoid, to make them understand that I can give them drugs to make them feel better, but it's up to them to decide whether they want to take that drug or not. So if they say, I'm living with this, I'd rather not take any extra therapy, if it's not a danger issue, then that's a perfectly acceptable concept. And part of the reasons why physicians have to get into this is because we tend to focus on things like pulmonary function tests, which really don't tell you about what the quality of life of a person is. It tells you about a number, and physicians like numbers like everybody else, we like a measurement. So what is danger? Because again, I'm going to talk about this more severe. So there are some organ failure problems. We've heard nice discussions about cardiac, neurologic, oculars, another one, liver failure occasionally, and then of course death. These are the areas that therapy has to be considered. So advanced sarcoidosis encompasses these different areas, and I'm going to focus on only a couple of them. I'm going to talk a little bit about lung fibrosis, and this is the data that we started seeing about 10 years ago, that there's an increased mortality over the last 10 years compared to the 1960s. And this increased mortality is more common in all 4 groups, that is male and female, African Americans and Caucasians. The impact is a little bit higher in African Americans, but it's across all 4 groups. And why do they die? Well, there's this group of patients who die, most commonly they die from respiratory failure. Now, I always try to tell my patients about the stage of sarcoidosis has nothing to do with the impact of the disease. The stage is the stage of the chest x-ray. So stage 1, stage 2, stage 3, and stage 4, you already introduced about this. And stage 4 is fibrosis. And it sounds bad, but stage 4 in cancer means spread throughout the body. And you've already realized that sarcoid can be anywhere in the body. So I have patients who have a stage 1 chest x-ray. Their problem isn't their lungs, it's their eyes or their heart. So the stage tells you about what's going on in the lungs, at least in the x-ray. So stage 4 are patients with fibrosis. If we look at who dies from sarcoidosis, they die, as I said, usually from respiratory failure. This is an early study we did looking at patients in our institution we followed for 10 more years. And we saw that the deaths that we saw, the majority of them, over 90% of them, were from respiratory, and they all occurred in the patients who had fibrosis on their x-rays. However, of the patients with fibrosis on their x-ray, only 20% went on to die. Most of them did well. And so just because you have scar tissue on your chest x-ray does not necessarily mean you're going to die from the disease. And this is just 2 other studies, one from France and one from England, showing the same thing, that the lung function test can be quite good in patients with scar tissue of the lung. So the last couple of years, and we've been really trying to figure out who, when I'm sitting there looking at somebody whose x-ray shows scar tissue, should I be worried about? And we do now have some a scanning with a score developed by Simon Walsh and Ethel Wells, where they looked at how bad the lung function tests were, the presence or absence of fibrosis on the x-ray. And this Walsh score, if you had a positive score, meant that you were more likely to die from the disease. Not only is this prognostically important, we've just launched a study where we're using drugs specifically for pulmonary fibrosis. We do have some drugs that are available for pulmonary fibrosis and other conditions, and so we're doing a study of the drug called pirfenidone for patients with fibrotic lung disease that we're worried they're at risk. We don't think that everybody with fibrosis needs that drug because 80% of the people are going to do well. The drug's expensive, has a lot of GI side effects and other things, but we're focusing on those patients who are going to do poorly. We in fact looked at, to be sure, before we started the study, we looked at our population in Cincinnati and again showed that if they had a bad score, that subgroup of patients, that's what you would consider. This bad score would also say what other things you should consider. You're at the home of lung transplant, so that would be another consideration. If you have a bad score, that should be considered. Again, not everybody has advanced pulmonary sarcoidosis, needs to be considered for that. That's fibrosis. The other condition of the lung is pulmonary hypertension, which has not been discussed just briefly, but is a serious problem in patients with advanced lung disease. It depends on how hard you look. If you look at all patients in a clinic, about 5 to 15% will have pulmonary hypertension. But if you look at patients who are still short of breath, despite getting steroids, infliximab, all these other drugs we give, about half those patients have pulmonary hypertension. That's why they're not getting better. And if they go off to get transplant, refer for transplant, 70 to 90% of the time you see that. Because pulmonary hypertension does not respond to anti-inflammatory therapy. This is a study, again, at our institution, where we looked at 130 patients in a row that we sent off for right heart catheterization because I couldn't make them feel less short of breath. And what we found was that they had a normal pressure. That means they didn't have pulmonary hypertension. Only 3 of them died. Whereas on the far right, if they had pulmonary hypertension, called precapillary, due to the blood vessels clamping down in the lung, unfortunately about 1/3 of them died. This is because we were not treating pulmonary hypertension. We now have drugs for pulmonary hypertension. They're used on patients with called idiopathic pulmonary hypertension. And we've done a couple studies on these drugs in sarcoid patients with pulmonary hypertension. This is one from a few years ago where we looked at patients with pulmonary hypertension. We gave them a drug called bosentan, and we showed that their pressures got better. And that's just the squiggly lines that they go down, that's improvement. Whereas if we gave them placebo, there was no change. So the drug was working on the pressure. Unfortunately, over this 4 months of the study, the patients didn't walk any further. They didn't feel that much better. So we were happy, not necessarily they were. We did an extension where we gave the patients drugs for the next year, and we saw a subgroup of the patients getting better. That is that they were walking farther, they were feeling better with that. Because pulmonary hypertension isn't the only reason why these patients were short of breath. They also had scar tissue in their lung. So there's kind of a tipping point that if you have a lot of scar tissue on the right, even if you have pulmonary hypertension, the scar tissue is going to be a problem. But on the left, if you don't have that much scarring, but you have a lot of pulmonary hypertension, then treating the pulmonary hypertension, opening it up, will make you feel better. So that's where this tipping point is. We think it's around 50% lung function. So if you're on the right, you're not getting any better, you're progressing your fibrosis, you may think about transplant, but if you're on the left, you may think about treating the pulmonary hypertension first to see how you're doing. We have a registry of some 260 patients with sarcoid pulmonary hypertension across the world, centers in the United States, Saudi Arabia, as well as most of Europe. And we can show that these patients are doing better now as we start to give them therapy for their pulmonary hypertension. So this is an algorithm, a way we think about as physicians. What do you give, what drugs do you start with, and how you treat it, and it's an approach to pulmonary hypertension. Not anti-inflammatory. I didn't put prednisone in here or the other drugs we say don't really work for this problem. We've heard nice discussions about cardiac sarcoidosis and neurosarcoidosis. And I want to finish up with just a comment about complications of the disease and therapy. In point of fact, one of the reasons why people don't do so well with their sarcoidosis and this advance is because we're treating them. Now, they have problems with their lungs. They have damage to their lungs, they develop scarring, they have more likely to get infections, but we're also giving them drugs that make them more susceptible to infections. Prednisone, infliximab, and such. So people who have been on steroids are more likely to have problems with taking the steroids, maybe than they are from their underlying disease. And infliximab is a wonderful drug, really like it, but it makes you more susceptible to things like tuberculosis and other infections. And at least 20% of our patients have to stop the drug, the infliximab, because of complications of infections or allergic reactions. This is one of the infections that we worry about. This little round thing in the middle here, this is called an aspergilloma, a little fungus ball sitting in there, and that's a complication of the disease. So if you have sarcoidosis, you need to monitor for danger. So how do we monitor? Well, for the pulmonary fibrosis, we do pulmonary function tests and the CAT scan. For pulmonary hypertension, we look at echocardiograms and do, for cardiac, you've already heard about Holter and the echocardiogram. For neurologic disease, you keep this in mind. You try to talk about what neurologic symptoms you have, and you look for infections. So I think that the concept of advanced sarcoidosis is something that we're trying to emphasize, not only to you in the audience, because most of you realize that it can be a serious disease, but also to your physicians, not to just tell you that don't worry about it, it's going to do fine. And you need to look at ongoing inflammation. You now look for fibrosis and these other complications such as pulmonary hypertension and neurologic disease. Partly because we do have treatment options for these other forms of disease, so you have to dissect out why are you still having symptoms, because you may need something specifically for that therapy. I want to stop by saying that, with this point, to emphasize that there are a list of sarcoid clinics. The WASOG, the World Association of Sarcoid and Other Granuloma Disease, and the FSR have put together a list. Kelly is actually the curator of that list, and I work with her about trying to keep up to date. And I'm pleased to see that WashU and I think SLU is also a sarcoid clinic. And so I think that these are places, if you live outside of this area, you should look for sarcoid clinics around your area. Thank you very much for your attention.